Well, I'd like to welcome everybody to this first virtual only session of the RSNA case collection hot seat. The cases presented here are all from publications on the RSNA case collection submitted by people in our community. And we've selected some really awesome cases for all of you to view and to basically take in a short amount of time. We have 2 cases per radiology specialty, and our moderators are our amazing trainee editorial board for the case collection, with presenters being members of our editorial board for that particular specialty. So I hope you enjoy this session. Hopefully we will have more of these coming on. We will definitely have live sessions at the annual RSNA meeting. So please join us in the future events as well. And I hope you enjoyed this one.
So good morning, everyone. My name is Matheus Zanon. I'm a PGY radiology resident at São Lucas Hospital in Porto Alegre, Brazil. And it's one of the members of the trainee editorial board. It's my pleasure to introduce Dr. Kush Desai. He's associate professor of radiology at the Northwestern University and our deputy editor in interventional radiology. And he'll be presenting really interesting cases in interventional radiology today.
Thank you, Matheus. Pleasure to be with all of you. So we're going to do our first case. This is a 48-year-old male admitted due to hypoxemic respiratory distress secondary to COVID-19 pneumonia. He's found to have bilateral lower extremity deep vein thrombosis. And on the initial imaging that you see here, we have a coronal post-contrast CT, delayed contrast phase. We have a digital subtraction angiogram, venogram, and then you have a fluoroscopic still image all the way to the right. May be difficult to see, but I would encourage you to look closely around the level of L3. Just to reproduce some of the images here for your benefit. What is the diagnosis? Is this transposition of the IBC? Is this duplicated inferior vena cava? Or is this a dilated left gonadal vein? And please enter on the poll. We'll give it about 30 seconds total, or once I see the bars stop moving. Okay, moving along. Trying to advance it. I think we need a little bit of help advancing it. I'm unable to advance it here. There we go. So what is the diagnosis? This is a duplicated inferior vena cava. We'll go to the case explanation. So caval duplication is a relatively common anatomical variant. Duplications can be partial, can be complete, almost form a vascular ring, as you see in this image here, where the left moiety has a connection both cranially at the level of the left renal vein, as well as caudally at the level of the right common iliac vein. In a duplication, the left iliac vein empties into the left renal vein, as I just mentioned. And it's important to notice this mostly for the perspective of vena cava filter placement. If you do not place a vena cava filter either in the suprarenal segment, where of course it's off-label, and you miss one of the moieties, that provides a conduit for thrombus to embolize from the lower extremity deep venous structure. So something to be very careful of. If you don't have pre-procedural cross-sectional imaging, axial imaging, then you need to park a flush catheter within the left iliac vein itself to ensure that you are completely imaging the inferior vena cava and excluding variant caval anatomy. On to our next case. This is a woman with a history of non-alcoholic steatohepatitis related cirrhosis, initially who presented with melena and was found to have profound anemia with a hemoglobin of 6.6. She required hospitalization and transfusion. You can see a representative post-contrast coronal CT reconstructed image right here. Here we have two images from digital subtraction angiography, selective angiography of the celiac axis. And you can see conventional anatomy as well as some enhancement that you see here in the gastric cardia and fundus. So what is this diagnosis? Is this gastric antral vascular ectasia, or GAVE or GAVE, esophageal variceal bleeding, a doulofoid lesion, or a gastric ulcer? And the poll is open now. And of course, we have the CT image here that shows the enhancement pattern that we'd like you to focus on. Give it a few more seconds. Okay, and we'll move on to the answer now, and I may need someone to advance it for me again. So the diagnosis is gastric antral vascular ectasia, or GAVE. An esophageal variceal bleed would, of course, show an esophageal, probably free focus of extravasation. This is more of a mucosal enhancement pattern. Same with the doulofoid lesion and a gastric ulcer. You usually are broad-based. You see focal extravasation or pseudoaneurysm. Here you see mucosal enhancement both on the CT image as well as the two digital subtraction celiac images. So bleeding in the setting of cirrhosis may be variceal, arterial, or associated with small vessel vasculopathy, which is what we have here. And in these patients, ectasia of antral submucosal vessels can be a source of bleeding. This is supported on CT and can be incidentally noted on angiography, but is not usually treated endovascularly. Thank you.
Hi, my name is Megan Mercer, and I'm a resident at MUSC. I'm here to introduce our breast imaging deputy editor, Dr. Yiming Gao from NYU.
Thank you for that introduction, and we'll move right on to the breast cases. So case number 1 is a 60-year-old woman who presented with left breast pain. A diagnostic exam was performed, and here you see left MLO view of the breast that was negative for any findings within the breast. The incidental finding here that's electronically zoomed for you is an isolated 1 or 2 prominent hyperdense axillary lymph node. And I would note that this finding is unilateral. Targeted ultrasound was performed and demonstrated this finding. And this is correlating with the prominent lymph node on the mammography. And as you can see, there's some echogenic foci within the nodal cortex. Percutaneous ultrasound guided biopsy was performed with the post-biopsy mammogram displayed on the left. And you can see a biopsy clip marker denoting the site of sampling and correlates to the previously noted lymph node. So what is the diagnosis? And you can go ahead and start entering your answers. Is this gold therapy for rheumatoid arthritis? Is this intranodal tattoo pigment? Is this granulomatous disease? Or is this nodal metastatic disease? We'll give just a few seconds. Okay. So we're going to move on, and you can continue to enter your answers. I think most people are onto the correct diagnosis. And it seems I also need help advancing to the next slide, please. Thank you. Excellent. So the correct answer is intranodal tattoo pigment, and it looked like most people got it. So gold therapy for rheumatoid arthritis is, of course, going to be bilateral findings and typically more extensive involvement of numerous more bilateral axillary lymph nodes. And granulomatous disease typically also would be bilateral involvement. And what you would expect to see are very large dystrophic calcifications involving both sides. And nodal metastasis is going to be unilateral. And calcified axillary nodal metastasis is actually fairly uncommon for breast primaries and more commonly seen in the setting of post-neoadjuvant chemotherapy due to tumor necrosis. And other primaries that are known to metastasize to axillary lymph nodes include, of course, ovarian cancer and thyroid carcinoma. So a word about intranodal tattoo pigment. This is actually a rare case of biopsy-proven intranodal tattoo pigment retention in axillary lymph node. Of course, in clinical workup, you're going to, look at the patient, do a physical exam, and have clinical history to help you confirm that. And in this case, we can beautifully see the ink retention within the node on X-ray, both on X-ray as well as on ultrasound as echogenic foci within the nodal cortex. And of course, this being foreign body incites reactive hyperplasia of the lymph node. And the pathology slide in this case beautifully shows the coarse granular black metallic ink within the cytoplasm of intranodal macrophages, which we can visualize on different imaging modalities. So moving on to case number 2. This is a 21-year-old woman who presented with asymmetric enlargement of her left breast over the past year. Importantly, she is not pregnant or breastfeeding. She has no family history of breast cancer. And I'm showing you bilateral MLO mammographic views to show the asymmetric involvement of the left breast. Targeted ultrasound was performed and demonstrates an 11-centimeter mass in the left breast, which correlates with mammography findings. And as if you can see, take a moment, look at the margins of the mass and look at the internal echo texture of the mass. And here's a Doppler image that shows presence of internal vascularity. So knowing that, what is the answer? And you can go ahead and begin to enter on the poll. Is this juvenile hypertrophy? Is this giant juvenile fibroadenoma? Is this a case of phalloides tumor? Or is this invasive ductal carcinoma? Yeah, this is a tough distinction between these two. I do agree. And I'll give it a few more seconds. And I think we can move on to the next slide. And for those of you who haven't decided, you can continue to enter your answer. So the correct answer is giant juvenile fibroadenoma. Juvenile hypertrophy is actually diffuse breast enlargement due to abnormal overgrowth in response to surge of estrogen seen in younger patients. And the hallmark is, of course, it's breast enlargement without underlying mass. And you could see that unilaterally or bilaterally. So clearly we see a mass in this case, so that's not the case. Phalloides tumor, as many people pointed out, radiologically and clinically can be indistinguishable from the imaging set that I just showed you. But this patient is only in her 20s, and the typical demographic that phalloides tumor is seen in is much older, in their 40s or 50s typically. And invasive ductal carcinoma, while some of the subvariants can be very circumscribed, at this size, an invasive cancer you would really expect associated central necrosis, and the margin is never going to be this smooth and beautifully circumscribed. So the correct answer is giant juvenile fibroadenoma. And this is essentially a larger subset of giant cellular fibroadenoma fibroadenoma. And the clinical diagnostic criteria is whenever it is greater than 5 centimeters in size and occupies more than 80% of the breast volume. Again, the hallmark is rapid growth, which is also seen in phylloides tumor. On pathology, you typically see increased stromal cellularity and epithelial hyperplasia. And again, because of the overlap, even on pathology with phylloides tumor, and again, because it's often very symptomatic for these patients, surgical excision is typically performed to clinch the definitive diagnosis. And as you can see, when they are large, they can have internal cystic spaces and clefts. So thank you for your attention. That concludes the breast cases.
So it's my pleasure now to introduce Dr. Christopher Walker. He's Associate Professor and Vice Chair of the Faculty of Development in the University of Kansas, and our Deputy Editor in Cardiothoracic Imaging. And we present really interesting cases in cardiothoracic.
Thank you very much for the introduction. So let's start off with case 1. This is a 62-year-old woman with breast cancer, and she presents with progressive shortness of breath and wheezing with exertion. We have an axial inspiratory CT on the top left, and then we have an expiratory CT on the right, as well as a dotatate PET scan in the bottom left. And so what is the most likely diagnosis? Is this metastatic primary lung cancer, diffuse idiopathic pulmonary neuroendocrine cell hyperplasia, hypersensitivity pneumonitis, or metastatic breast cancer? Give some people some time to answer. So the correct answer here is diffuse idiopathic pulmonary neuroendocrine cell hyperplasia, and most of us got that correct. And so what is DIPNIC? So DIPNIC is a condition that typically affects middle-aged to older women, and it typically manifests with well-circumscribed nodules with mosaic attenuation on inspiratory images and air trapping on expiratory images. Dotatate PET is often useful in diagnosis because it will show uptake within these carcinoid tumors. So in this example here, you can see this large, well-circumscribed nodule in the right lower lobe. Notice how it's closely associated and has branching morphology typical of a carcinoid tumor, is there is also pretty extensive mosaic attenuation affecting both lungs, very common manifestation of DIPNIC. And on the expiratory image I showed, it showed pretty extensive air trapping, so accentuation of that mosaic attenuation pattern, typical of DIPNIC. Let's go to case 2. This is a 41-year-old man who has a history of ulcerative colitis, presents with a 4-week history of progressive shortness of breath and dry cough. We have an axial CT scan on the left and a coronal CT scan on the right. Importantly, this patient presented before the COVID-19 pandemic happened. And so what is the most likely diagnosis here? And again, this is prior to the COVID pandemic. So is this viral pneumonia, organizing pneumonia, bacterial pneumonia, or eosinophilic pneumonia? Most people are choosing organizing pneumonia, and then several are choosing eosinophilic pneumonia. And the correct answer here is actually organizing pneumonia. And so on this axial CT, there are several features that are very suggestive of organizing pneumonia. Notice how there's bilateral consolidation. The consolidation seems to be intimately associated with the bronchovascular bundles. And then this arrow here on this other image shows this perilobular distribution that's very common with organizing pneumonia, where you have the organizing pneumonia actually marginating the periphery of the secondary lobules. And then you also have some central ground glass opacity within that consolidation, very typical of the reverse halo sign. And so organizing pneumonia is a very common manifestation of COVID-19 pneumonia. So we see this fairly common with COVID-19 pneumonia. But remember, organizing pneumonia can be caused by a wide variety of insults, in this case, associated with the patient's inflammatory bowel disease. The typical manifestations are very varied. And so we often will see peribronchial vascular or subpleural consolidation in ground glass opacities. We see this perilobular distribution in about 60% of cases. Again, where that organizing pneumonia manifests in surrounds those secondary lobules. And then we see the reverse halo sign in about 20% of patients. And thank you for your attention.
Good morning, everyone. I'm Dr. Vicini, radiology resident at Sapienza University of Rome, Italy. It's my pleasure to introduce Dr. Douglas Katz, professor of radiology at New York University, who will be showing some interesting gastrointestinal cases. Thank you, Dr. Katz.
Thank you. Good day, everyone. Our first case is a woman with a history of recurrent spontaneous epistaxis, nosebleeds, recurrent lower GI bleeding, who had sudden onset of right upper quadrant abdominal pain and so underwent this CT. It's a multiphasic CT. These are arterial phase representative images through the liver and lower chest. And you can see the liver is really quite abnormal here. And there is also a vascular nodular focus at the right lung base. On the somewhat delayed images, we see washout of the liver, but still a lot of heterogeneity, as well as some washout of the vascular nodular focus at the right lung base. And so given these CT images in the history, is this Osler-Weber-Rondeau syndrome, Budd-Chiari syndrome, is this passive hepatic congestion, or is this hepatic veno-occlusive disease? And so everyone go ahead and vote. We don't have the Jeopardy music this morning, but I'll spare you. I won't sing while you put in your choices. Okay, give it a few more seconds. Last minute takers. Okay. And so the diagnosis is Osler-Weber-Rondeau syndrome. And so the combination of the history, as noted with the CT findings, essentially are pathognomonic or diagnostic of this disorder. It's also known as hemorrhagic hereditary telangiectasia, HHT, or hereditary hemorrhagic telangiectasia. And the liver is involved in a substantial minority. It's about like 15 to 20% of affected individuals. This is a genetic disorder. And when the liver is involved, it's really quite typical what we're seeing here in terms of really very crazy, wild shunting, numerous shunts throughout the liver, very, very bizarre appearance that really is not seen in any other disorder. And we see the AVM at the lung base as well here. Our second case, another liver case, very different sort of diagnosis here. This is a woman with a history of poorly differentiated pancreatic adenocarcinoma. She has had a variety of treatments, including focal resection, neoadjuvant chemotherapy, and then additional radiation therapy and chemotherapy following that. So it's been going on for several years. And she presents with an MR for follow-up. The representative MR images here demonstrate a new focal finding in the liver. Those. And then we have some additional axial and coronal images of the liver, multiphasic with contrast on board. And so what is the best diagnosis here? Is it focal nodular hyperplasia, or FNH? Is it HCC, hepatocellular carcinoma? Is this a new hepatic metastasis, or is this a hepatic adenoma? So go ahead and vote. And I'll tell you, I hadn't heard of this entity until a few years ago when it became somewhat increasingly recognized, to my knowledge, initially in the pediatric oncologic population, the reports of this occurring. And so let's go ahead and look at the answer. The answer is FNH, focal nodular hyperplasia. And so, if this was in a different clinical setting, it probably would be easier and we would be less likely to think this was a potential metastasis. But this has been increasingly recognized to some extent in both the adult and the pediatric oncologic population on imaging. The exact mechanism is not entirely clear to my knowledge, but there are some thoughts about why this occurs. This particular patient was on oxaliplatin, which is an associated chemotherapy agent to provoke the development of FNH, either singular or multicentric. And as with this entity, which is much more common in other scenarios, typically very similar in signal to the liver on all sequences, pre-contrast or slightly different, a little bit higher in signal, as you see here in the T2 weighted images. And then this enhances usually pretty briskly and uniformly. And then the contrast extends out and the abnormality becomes relatively iso-intense to the adjacent liver, or maybe difficult to see at all. Sometimes this entity is really very difficult to see at all without the intravenous gadolinium-enhanced images. And with that, I appreciate the honor to present today, and I'll turn things over to our next introducer and presenter.
Hi, everyone. My name is Richa Patel. I'm a PGY5 diagnostic radiology resident at the University of Washington. It is my pleasure to introduce Dr. Kianush Hossain-Zadeh, a radiologist at the Veterans Administration in Durham, North Carolina, who will be sharing some interesting genitourinary cases.
Thank you very much for the introduction. I welcome the audience. Here are two cases I'm going to present to you in GU. The first case is an 81-year-old woman who presents with intermittent left flank pain and chills. Her symptoms improve after bowel movement and with prone positioning, and she denies any history of hematuria. So here's an axial image through the left kidney that shows hydronephrosis. Series of coronal multiplanar reformatted images from left to right, going from anterior to posterior. And the last image on the right is a sagittal NPR image. I draw your attention to the course of the ureter. This is a retrograde ureterogram going from left to right. The first image is just injection through the ureter. The second image is placement of the guide wire. The third image is placement of a stent over the guide wire. And lastly, the guide wire is removed, leaving the stent in place. So spend a few seconds looking at these images. So what is the diagnosis? You have four options: UPJ obstruction, secondly, ectopic ureter, third is uterosciatic hernia, and then fourthly is primary megaureter. If you want to start your voting. Spend a few more seconds. All right, things have stabilized. Can you move to the next slide, please? So the answer is uterosciatic hernia. This is actually an ant mini. There's really nothing else that can look like this. So uterosciatic hernias these are acquired hernias, and this occurs when the pelvic portion of the ureter herniates through the sciatic foramen, and it can actually cause intermittent obstruction. So on the retrograde study, the yellow arrow points to the curly Q appearance of the ureter, and this is where the afferent and efferent limbs of the ureter herniate through the sciatic foramen, and they're closely opposed to each other, and that's why it's called a curly Q appearance. It can cause intermittent obstruction. It can resolve spontaneously, for example, the patient lying in the prone position or with bowel movements as it occurred in this case. And the hernia can also reduce during wire and catheter manipulation. But the definitive management for this hernia is surgical correction. All right, let's move on to the next case. A 4-year-old girl presents with left abdominal pain and flank mass on physical examination. So an ultrasound image here, grayscale on the left of the left upper quadrant, the region of the kidney. And then you have the color Doppler image on the right. So it's difficult to differentiate this mass from the kidney. So the patient underwent a CT examination. You have an axial image on the left and the coronal image on the right. And again, I want to draw your attention to the relationship of the mass to the kidney itself. Spend a few seconds here. So what is the diagnosis? 4 options. First one, renal cell carcinoma, lymphoma, neuroblastoma, and Wilms tumor. If you want to start voting. Okay, things are stabilizing. A few more seconds. All right, if we can move to the next slide. Let me see if I can do it. Okay. So the answer is correctly, as most of you suggested, is Wilms tumor. So the key imaging feature is to look for the claw sign. And this tells you that the mass is intrarenal in location and arises from the kidney. Now, out of the options provided, Wilms tumor and renal cell carcinoma occur within the kidney, so they arise within the kidney. Now, Wilms tumor is the most common solid neoplasm in the pediatric population in the first decade, 80% of them occurring before the age of 5. Renal cell cancer, it can occur, but it's extremely rare, and it usually occurs in the second decade. So these are heterogeneous masses that are intrarenal location. They cause displacement of structures as opposed to an infiltrated process. Lymphomas and neuroblastomas typically result in an infiltrated process, so they secondarily involve the kidney itself. And also, neuroblastomas, the median age for neuroblastoma is usually 19 months, so much younger. There's absence of calcification. Again, calcification can occur in Wilms tumor. It's uncommon, whereas in neuroblastomas, for example, 90% of them calcify. Well, thank you very much. This concludes GU, and I'll pass the baton to the next presenter.